Imagine you're a horse breeder. You've spent months, maybe even years, planning everything for your prized mare. She's showing all the classic signs, seems ready to breed. You do everything by the book, bring in the stallion, but nothing. She doesn't conceive.
Right, and it's more than just disappointing, it's incredibly frustrating.
Exactly. A common, baffling problem. Significant costs, too, financial and emotional. So today, we're doing a deep dive into exactly that. Equine ovulation failure. It's a really fascinating and critical aspect of mare reproductive health.
It really is. And at its core, equine ovulation failure is, well, it's when a mature, dominant follicle in an estrus mare just fails to ovulate. Seems simple on the surface.
But it's not, is it? The why and the what to do about it, that's where the complexity lies.
Precisely, and that's what really impacts breeders.
Absolutely. Because that 5 to 20% incidence rate you hear about for things like anovulatory hemorrhagic follicles, HAFs, we'll probably call them, that's not just a number.
No, it's significant.
It means, potentially 1 in 5 mares you might work with could face this. It really highlights how common, and therefore how critical this is. Any age, any breed, even smack in the middle of the breeding season.
It really underscores why we need to understand it clearly.
So our mission for this deep dive, let's unpack the different types of ovulation failure, explore how vets actually diagnose them, often with some pretty cutting-edge tools, and crucially, look at the different treatment strategies available to help get things back on track.
Sounds like a good plan.
Okay, so let's start with the ideal scenario. What should happen in normal mare reproduction? Understanding the success story helps us see where failure creeps in.
That's the perfect place to start. So normally, during estrus, a mare develops 1, maybe 2 mature follicles on her ovary. This growth sets off a crucial hormonal cascade.
Right, involving that LH surge.
Exactly. The luteinizing hormone surge, that key signal from the pituitary gland.
Yeah.
This surge then leads to prostaglandin production within the follicle, and that's the final go-ahead for ovulation. The follicle ruptures, releases the egg. It's a beautifully coordinated dance, really.
A dance, I like that. So where does ovulation failure trip up in this dance?
It's right at that final step. The follicle, even though it's mature, maybe even got the LH surge, it just fails to rupture. It doesn't release the oocyte.
So it just sits there.
Worse, it often continues to enlarge. And critically, it can become hemorrhagic, meaning it bleeds into itself, and its cells start to luteinize.
Okay, luteinize. What does that actually mean for the mare? Is it like her body gets tricked into thinking ovulation happened?
That's a really good way to put it, actually. The cells inside that follicle wall transform into what we call luteal tissue. Now, this tissue normally forms after ovulation and makes progesterone.
The pregnancy hormone.
Right. The hormone needed to maintain pregnancy.
Ugh.
But here it forms without an egg being released, so it creates this hormonal deception, which can really mess with the mare's cycle.
So these problem follicles get names, right? HAFs you mentioned?
Yes, HAFs, hemorrhagic and ovulatory follicles, is common, or LUFs, luteinized unruptured follicles. And sometimes, especially if they happen later in the season, you might just hear them called autumn follicles.
Okay, so confused follicles. What's causing this confusion? Is it one specific glitch, or are there multiple culprits?
Oh, definitely not just one thing. We can break it down into a few main categories. First is what we call physiological ovulation failure. Think of this as, well, the mare's body just being a bit out of sync, often seasonal.
Ah, so like a natural rhythm thing, not necessarily a major medical problem, like when mares are transitioning.
Exactly. Perfect way to describe it. During those transitional times, spring, coming into season, or fall, going out their hormones, FSH and LH, can fluctuate quite a bit. They get erratic,
Leading to
these large follicles that look promising. But without that strong, precise hormonal signal, they just, well, fizzle out. They never ovulate. Hence the autumn follicles nickname. They eventually just regress.
And what about foal heat? I hear breeders mention issues there sometimes. Is that similar?
It can be, yes. A mare's first heat after foaling, especially if she foaled very early in the year, can sometimes see a similar sort of blip. It's influenced by the season, the demands of lactation, her body condition. Her system is still adjusting.
So not always a crisis, sometimes just nature working itself out. Does age play a part too?
Definitely. Unfortunately, as mares get older, we particularly see an increase around 16 years and up. These anovulatory follicles just become more common. It's a natural part of ovarian aging, really.
Okay, so that covers the physiological side. What about when things go wrong during the main breeding season?
Right. That's when we move into pathological ovulation failure. This is often more concerning because it's happening when everything should be working properly. And here, we're mostly talking about those AHFs and LUFs again.
The anovulatory hemorrhagic follicles and luteinized unruptured follicles. What makes them different from the transitional ones?
The key difference is that a seemingly normal pre-ovulatory follicle starts bleeding into its own lumen, its internal space, and then it luteinizes without ever rupturing.
And they can get big, you said?
Oh yeah, sometimes quite large, 5 to 15 centimeters even. And they can persist for weeks, sometimes months. This can throw a mare's cycle completely off, causing a prolonged diestrus that's the phase between heats or really erratic heat behavior.
So what triggers that internal bleeding and luteinization in these cases? Do we know?
Frustratingly, the exact cause in spontaneous cases often isn't known, but we do know they can be induced sometimes.
How so?
Well, for example, high doses of certain anti-inflammatory drugs, COX inhibitors, can sometimes trigger them. And there's some ongoing debate about whether using PGF2, a common hormone used to manage cycles, might contribute, if used perhaps at an inopportune time.
Wait, so a drug used to help manage cycles might sometimes cause this problem. That sounds tricky.
It is, and it comes down to very careful timing and appropriate use by the vet. It's not a common side effect when used correctly, but it's a known potential interaction. Beyond AHFs and LUFs, pathological failure can also happen if there's just not enough gonadotropin stimulation.
Not enough LH.
Exactly. The pituitary isn't sending a strong enough signal. Or sometimes the follicle itself isn't producing enough estrogen. There's even some research linking it to chronic uterine inflammation, endometritis.
And what about tumors? Do they fit in here?
They do. Specifically granulosa thickest cell tumors, or GCTs. They're the most common ovarian tumor in mares. What's fascinating is that they don't usually cause failure in the ovary they're on.
Really? How do they cause problems then?
They act like little hormone factories gone wild. They pump out hormones, mostly inhibin and sometimes testosterone, which then travel through the bloodstream and suppress normal activity, including ovulation and the other, healthy ovary.
Wow. So one rogue ovary shuts down the other one. That's quite something.
It leads to things like anestrus, the mare, stops cycling completely, or very abnormal cycles.
Okay, one last category. What if the mare just doesn't respond to the drugs vets use to induce ovulation?
That's our third category. Failure to respond to ovulation-inducing agents. Sometimes, even with drugs like HCG or GnRH agonists like dyslorelin, the mare just doesn't ovulate. Usually this means the timing was off, the follicle wasn't quite ready when the drug was given,
Or the follicle is already abnormal.
or the follicle was already developing abnormally, maybe already on its way to becoming an AHF. It's a reminder that timing and follicle health are absolutely critical.
So with all these possibilities, seasonal, pathological, tumors, drug response issues, how do vets actually figure out what's going on? Diagnosis sounds key.
It absolutely is. And the gold standard, the primary tool, is regular reproductive examination using transrectal ultrasonography. Serial exams scanning repeatedly over days are the most important diagnostic tool.
You need to track the changes, or lack thereof.
Exactly. You need to see how that follicle is behaving over time. Is it growing normally, changing shape, ovulating? Or is it just getting bigger, developing internal echoes, and sticking around?
And besides the ultrasound, what else contributes to the diagnosis?
It's a whole picture approach. The vet will look at the mare's reproductive history, her age, foaling dates, any past problems. Transrectal palpation is still important, feeling the ovaries for size, the follicles, checking uterine tone.
And the mare's behavior.
And behavior, absolutely. Teasing records are vital. Is she showing prolonged heat, erratic heat, or maybe no heat at all, suggesting a persistent luteal structure?
Okay, back to the ultrasound, the detective work. What are the visual clues? What does a normal follicle look like versus a problem one?
Great question. So a normal pre-ovulatory follicle grows, typically 35 to 50 millimeters, sometimes larger.
Right.
It often becomes sort of pear-shaped as ovulation nears. It softens on palpation. And importantly, the wall thickens, but the fluid inside stays clear, black on the screen.
Clear and black. Got it. And after ovulation?
After ovulation, you see the collapsed structure,
Yeah.
the corpus hemorrhagicum, which quickly organizes into the corpus luteum, or CL, the progesterone producer.
And the anovulatory ones, the AHFs or LUFs?
They fail to rupture. They often keep growing, getting abnormally large, maybe over 50, even 70 millimeters. And this is where the ultrasound gets really telling.
How so?
Instead of that clear black lumen, the inside of an AHF often shows distinct speckles, maybe fibrin strands, or sometimes even a spiderweb appearance.
Spiderweb. Wow.
Yeah, it's quite distinct. That indicates bleeding and clot formation happening inside the follicle. The wall also thickens and luteinizes, And these things just persist much longer than a normal CL thing, 20 days, up to 2 months, sometimes even longer. That's what delays the next heat cycle.
That visual is powerful. And what about the tumors, the GCTs? Do they look different again?
They do. Ultrasound typically shows one ovary significantly enlarged, often with a very characteristic honeycomb or multicystic appearance. Lots of little fluid pockets. And the key finding alongside that,
The other ovary.
the other ovary is usually small and inactive, suppressed by the hormones from the tumor.
Okay, ultrasound gives the visuals. Are blood tests used to confirm things?
Yes, blood tests are a really valuable addition. Checking serum progesterone levels, specifically looking for levels over 1 nanogram per milliliter, confirms that luteinization has happened in that suspect follicle. That's crucial for deciding on treatment.
Any other useful blood tests?
Well, serum ECG can sometimes help determine if a very early pregnancy was lost, something that happened after the endometrial cups formed. And for suspected GCTs, testing hormone levels like inhibin, testosterone, and especially anti-Mullerian hormone, AMH, can be very helpful in confirming the diagnosis.
Right, AMH is a big one for GCTs now. Okay, so we found the problem, we've diagnosed it. Now, the big question, what do we do? Treatment must really depend on the specific cause, right?
Entirely. The approach is completely tailored. For that physiological anovulation, the transitional mares, maybe some foal heats often, you don't need specific drug treatment. Patience is key.
Just let the season progress?
Often, yes. But you can help things along. Putting mares under lights 14 to 16 hours a day, starting back in December or January, can definitely hasten the onset of regular cycles in the spring.
And hormones.
Oral progestins, like Altranagis brand name Regumate, is common. Giving that for 7 to 10 days can help sort of jumpstart mares out of transition, synchronize them a bit.
Good options for those seasonal cases. But what about the trickier ones? The AHFs or LUFs that are causing trouble mid-season?
Okay, for AHFs or LUFs, especially if they have luteinized and are producing progesterone, the main treatment is a prostaglandin, PGF2.
Like Lutalize.
Lutalize is a common brand name, yes. Or analogs like cloprostanol.
Yeah.
This hormone basically targets that luteal tissue and tells it to regress luteolysis. It hits the reset button on the cycle.
And timing is important here too, I assume.
Absolutely crucial. You typically wait until about 9 to 14 days after you first detect that anovulatory follicle. This gives it enough time to develop sufficient luteal tissue to actually respond to the prostaglandin. Give it too early and it won't work.
So wait for it to become responsive, then reset.
Exactly.
Yeah.
This shortens that prolonged diestrus phase and allows the mare to return to estrus, hopefully for normal ovulation next time.
Now, prostaglandins, they can have side effects, right? What should people know?
They can. In horses, PGF2 can cause some temporary sweating, maybe mild colic-like signs because it stimulates smooth muscle. Usually this passes within an hour or two.
But there are safety warnings too.
Yes, very important ones. PGF2 should not be handled by pregnant women or anyone with asthma or similar respiratory issues. Skin contact should be washed off immediately. And it shouldn't be used in mares that have equine asthma or other bronchoconstrictive conditions. Vets handle it carefully.
Are there alternatives with fewer side effects?
Cloprostanol sodium, often sold as Estrament, is an analog sometimes associated with fewer side effects. So it's technically not approved for horses in some regions. Vets may use it appropriately. And for very large, persistent structures and specialized clinics, they might do follicular aspiration.
Physically draining it.
Basically, yes. Using ultrasound guidance to puncture and drain the fluid, collapsing the structure. It's more involved, requires expertise.
So for AHFs, it's about targeted regression. What's a definite don't do?
The big don't is repeatedly giving ovulation-inducing drugs like HCG or deslorelin to an AHF. Once it's hemorrhagic and luteinized, you can't force it to ovulate. It's futile and might even make things worse. You need to address the luteal tissue first.
That's a really key takeaway. Don't push what's already failed. Okay, what about that third group, the mares, who just don't respond to the ovulation drugs in the first place?
For failure to respond to ovulation-inducing agents like we touched on, the most common reason is simply that the follicle wasn't mature enough when the drug was given. The timing wasn't quite right.
So we'll reevaluate.
Reevaluate the timing. Maybe try redosing if appropriate, or sometimes switching agents, trying GnRH if HCG didn't work, or vice versa might be considered. And finally, for the ovarian tumors, the GCTs.
Surgery.
Surgery is the definitive answer. Ovarectomy, removing the affected ovary.
Okay, we've covered the what, why, how to diagnose, and how to treat. Let's talk outlook. What's the prognosis for mares that experience these issues? Can breeders generally expect a good outcome?
It really, really varies with the cause. For the physiological anovulation, those transitional follicles, prognosis is excellent. Once the mare is fully cycling in the prime season, she's usually fine.
That's good news. What about the AHF-SLUFs?
For AHS and LUFs, after you treat them correctly with prostaglandin, the prognosis for the next ovulation is generally good. The cycle where the AHF occurred is lost for breeding, obviously, but subsequent cycles are often perfectly normal.
But can they happen again?
They can. Some mares do seem prone to developing repeat AHFs even in the same season, which definitely makes management more challenging. And for the GCTs, after surgery,
What's the outlook then?
prognosis for return to fertility after removing the tumorous ovary is also generally good. However, it can take time, sometimes months, occasionally over a year, for that remaining, previously suppressed ovary to fully wake up and resume normal function.
So even removing a tumor isn't an instant fix for fertility. Patience is needed there too.
Definitely. Now, where the prognosis gets more guarded, maybe even poor.
Is when you can't find a clear cause.
Exactly. If no treatable cause is found, and a mare just consistently fails to ovulate normal follicles, we call that idiopathic or chronic ovulation failure, then the outlook for conventional breeding can be quite poor.
Are there options for those mares?
They might become candidates for more advanced and usually costly assisted reproductive techniques like oocyte pickup, collecting eggs directly from the follicles for ICSI and embryo transfer, assuming they're still producing viable eggs.
This whole conversation just highlights how crucial expert veterinary care is, doesn't it? It's not simple.
Absolutely critical. Close, regular reproductive monitoring by an experienced equine vet is essential for the diagnosis, for figuring out the why, and for implementing the right treatment at the right time. It's dynamic management.
What an incredible deep dive. We've gone from, observing the mare to ultrasound diagnostics, hormonal treatments, even surgery. It really shows the complexity behind getting a foal in the ground.
It really does. It highlights how intricate reproductive biology is, but also how far veterinary medicine has progressed in understanding and tackling these challenges. It gives breeders better tools and strategies.
It certainly seems like a blend of patience, really precise diagnostics, and then those targeted interventions are needed to navigate what sounds like a super frustrating issue.
It can be. And the ongoing research trying to understand why these follicles fail at a fundamental level and developing even better diagnostics and treatments, it's constantly moving forward. It's quite remarkable.
So as we wrap up, what does this all mean for you, our listener? Thinking about the future of equine breeding, understanding this level of reproductive health, are there broader implications? Could learning about why mare follicles fail maybe even teach us something about fertility challenges in other species, perhaps even in human medicine? Something to think about.